Okay, so let me share my slide. A lot of this should be review for anybody that's been here about a year from our Joint Commission survey in 2023. We had a lot of different findings, which are to be expected. Some of them were a surprise, and some of them should not have happened. But nonetheless, here we are. And we want to make sure that let me move this out of the way. There we go. That you know what to prepare for when Joint Commission comes again. We are expecting them to be here sometime this month, if not in February. We're hoping they come sooner because we're ready. As we get ready, we want to make sure that they see all the hard work. So a lot of this will just be review for you guys. Want to make sure that you know what to expect. So you can see here, everything in red is something that was a finding. It's a lot of stuff. However, again, we are the biggest department in the hospital, and nursing touches every aspect of patient care. So it's to be expected that we would have more things under nursing than say UM. So we're going to go over all of the stuff in red. It won't take a lot of time, but just so that you know kind of what we're looking at specifically. We cannot get a finding in any red zone. It will not be a good thing. So we're really hitting these hard. So you can see here, again, more stuff. The biggest thing is our suicide prevention plan. So this is the number one way we keep our patients safe. And there's a couple different levels that we do with this. So the first thing we do is an environmental risk assessment, which means we identify what the patient's individual risk is, and then we do different things while they're here, mitigation strategies, while they're here to make sure that we are preventing them from hurting themselves. And that includes the CSSR that is done in intake. So the very first thing that we're going to go over is the environmental risk assessment. This was done by several leaders. This is done hospital-wide, where we are identifying every possible thing that could harm our patients. And then we come up with a plan for each one of those. So first identification, you'll see here, this is a bag, a blue bag inside the linen bin. That's a risk because patient can strangle themselves, choke themselves, eat it, choke someone else, or try to strangle someone else. So that's a risk. If you see it on the cottage, it needs to be removed ASAP. Anywhere that a patient can fit any article of clothing between two surfaces is considered a ligature risk. So this area between the wall and the sink, I can fit a sheet through there and I can probably hang myself. Same here with the shower. And then again, this vent that's falling apart. Cottage F, we understand that they have this little gap in their doors. So we've already identified a lot of this stuff. It is on our plan, saying that we're either going to monitor it or we have long-term solutions that we're going to put in place for them. Your job as the staff on the unit is identifying these things. If you see something, say something, something's broken, something looks like it could be harmful, you want to make sure you say something so that we can then have maintenance fix it. Joint Commission, again, mitigation strategies, the next thing that we would do is our plan. So what do we do as nursing? We do safety checks. We do purposeful rounding, supervising patients where ligatures are, such as the day room, or if you work on Cottage F, you know that those medical beds are ligature risk. So we make sure that we're monitoring them carefully in the rooms. Cottage B has that picnic table kind of thing in their day room. Someone should always be in the day room, making sure no one's trying to hang themselves off that table. And then again, making sure that we do work orders as soon as we see this. Purposeful rounding is direct visual observation, making sure you're checking for life, making sure you're assessing the environment. So the MHTs do walkthroughs every morning. You should be looking in the room for anything that shouldn't be there, take it out, and then as well as making sure that someone hasn't punched a new hole in the wall. And then, of course, document what you see and then communicating with your staff. We struggle with communication, even shift to shift. You should be doing a handoff with the nurses and with the MHTs on what happened during the day. Make sure you have all your patients, everybody's accounted for, so that you know who you have and what everybody's here for. The next thing, dating of jugs. So the water and the juice jugs that come to the units are only good for 24 hours. They should be labeled by the kitchen when you receive them. If they're not, please label them with the date. And then after 24 hours, they should be thrown away. We don't want any extra jugs. We have plenty of them, but please make sure we toss them. We don't want extra stuff that Joint Commission can potentially see. General environment of care, the cleanliness of our cottages. We all know this hospital's older. And so if you would see anything like this, please make sure you're letting the supervisor know, the program director, myself, MK, Shawan, so that we can send work orders on your behalf so we can get this fixed, because you're going to see this before I do. And they should never look like this. We don't want to get a surprise inspection and it looks gross on the cottages. So making sure you're reporting this. There is a maintenance help desk email. So again, once you tell one of us, we will send the email. There is urgent. If it's urgent, we need to be fixed, we address it as urgent. And then of course, after hours, we call the maintenance on call if anything major happens. So that is, for your information, how you follow work orders. You just let your program director or supervisor know, hey, I noticed this was broken or this needs to be fixed. And we usually take care of those. Shawan submits a lot of work orders after hours from second shift. Complaints and grievance. We do have a patient liaison, Shanika. Our job as nursing for complaints and grievance is to facilitate the complaint to the right department. It's not our job to try to change their opinion, fix the problem, unless it's something we can fix. But in general, our biggest job as a nursing department is just to say, I hear what you're saying. I understand that you feel however you feel, and you can either call this number that's posted on the unit, or you can give them a complaint form, and then we give that to Shanika or Jamie, the risk director, for them to manage. It's not our job to tell them that they're wrong, that we're going to fix whatever they're talking about or dismiss whatever they're saying. It is their right to file a complaint. And again, all we're doing is listening, saying that we tell them we're concerned and we're going to help address their issue, and then giving that to the right person to help fix. If their concern is about abuse, neglect, or any sort of rights violation, just notify the supervisor beforehand so we can go ahead and start that investigation. The patient advocate has a whole process that they follow. They have to respond within 24 hours. They have to report it to their director, and then they usually follow up again within 7 days, and then again at 30 days once the patient discharges. Again, for nursing, just knowing who we're directing those concerns to, either the director of risk or the patient liaison. So now if there's any MHTs on the call, you can go ahead and jump off. For nurses, however, we got a couple more slides to get through. So the next thing we're going to talk about is our suicide prevention plan. So we all know that we have Q15s and Q10s at Ridgeview. Of course, line of sights and one-to-ones, those are automatically Q15. What we want to make sure everybody understands is when a patient is placed on high-risk suicide and severe high risk, and that the precautions and observations match. So first off, you should be getting a high-risk notification routed to you from intake when they're bringing a patient to you. If you do not get the high-risk notification, or there is no intake assessment done, patient starts to code in the access center, maybe they're a geriatric that went straight to the cottage, at the minimum, that patient should be on Q10 and high-risk suicide precautions, period. So if you don't have anything from intake, put the patient on Q10 and high-risk suicide precautions, because that will cover us for that time where we don't really know why that patient is here or how they're feeling suicidal. You can look in the intake assessment. This just shows you how to get it from the table of contents. Go under suicidal, and it has the CSSR. So if this is empty, automatic Q10s, high-risk suicide. At the end of it, there is a score for the recent suicide intent. And then at the next, scroll down a little bit further down in that intake assessment, it tells you what to put the patient on. So for example, if they were to score a 16, they're high-risk suicide here in red, or if they score higher than 22, they're severe high-risk suicide. High-risk suicide, Q10, severe high risk, they should be put on a one-to-one or a line of sight, and we'll talk about that in just a second. There is also the high-risk notification form, where it also tells you what their score is. We have asked intake to start adding the number here. So you will see high risk score 20 so that you have it here. I always go to the intake assessment first. I will tell you, MK and myself are looking at every single chart that's coming the day after people are admitted. And so we're making a couple minor corrections here and there. I'm sending you guys chats if I have to make a correction to your charting. But I usually go to the intake assessment because it's more accurate than the high risk factor for notification may be. If you get a patient that is high risk suicide or severe high risk, this just shows you how to put the orders in, which you guys know how to do. Please make sure you put them on high risk suicide and regular suicide precautions because we will discontinue one at some point. Here is the stratification for the risk level. So severe high risk greater than 22 on that intake assessment, the patient should be on 1-to-1 or line of sight. Now, we all know we don't have enough staff to have 15 1-to-1s. So you have to use your nursing judgment and speak to the provider on this one, right? If the plan is for the patient to run, jump off a bridge or run into traffic on the 285, probably not going to happen on Cottage C. We can probably do line of sight for that patient. If their plan is to strangle themselves and maybe they made an attempt at the ER before they got here, probably need to put that one on a 1-to-1 because we could strangle ourselves on the cottage, right? So making sure you're using your nursing judgment. Do they need to be line of sight? Otherwise, Q10 for high risk suicide. The next couple pages go through what each precaution means and what we are going to do for the patient. I will post this on YouTube so you guys can slow it down if you want, but it basically talks about the stuff we already know. We're going to put an order in every 24 hours. We're going to search their room. We're going to search the patient. We're going to ask them over and over again if they're suicidal. Q10, what are we going to do for the, for line of sights? What are we going to do for a Q10? And then, of course, for standard observations, Q15. So usually the ones that get us is those severe high risk. You guys aren't noticing that they're scoring higher than a 22. So again, just being mindful of why your patient is here and what are they scoring on this, how suicidal are they? The next thing on here is daily nursing progress notes. Everybody that works at Ridgeview has been a nurse for a while, so you should know that you have to do a nursing note on every patient, every shift, period. If you did not do one because the nurse accidentally signed it off, cancel that sign in and make sure you do your note. You should be doing notes on every single patient. That's basic nursing care. So again, make sure that when you do your note, you are doing it correctly. The first question it asks you is if you're doing day shift or night shift. You hit day shift, then it'll ask you, is the patient on less than Q15? Terrible wording, but basically is a patient on Q10 and on severe high-risk suicide or high-risk suicide precautions? And you answer yes. If you answer yes, it will then open the CSSR in your note for you to complete. This is sometimes not done because I think nurses are going a little too fast and you're just checking no and no. But if your patient's on Q10s, it should say yes. If they're on line of sight or 1-to-1, you should be hitting yes here and answering those additional couple questions that come up. That ensures that we're following our suicide policy completely, okay? That's why it's important that we get them on the right precautions when they first get here. Usually not a big problem. Most of the nurses do a pretty good job on their notes. The bigger issue is making sure you have a note. Seclusion and restraint, not going to spend a whole lot of time on here. I audit every single seclusion and restraint chart. They look pretty good for nursing. So putting in an order, you go to add favorite, you pick the restrictive intervention. It'll automatically check everything. So then you put in your physician, you pick which order you want, 4 hours for adults, 2 hours for our kids on A and B. And then of course, these are all of the orders. While they are in seclusion restraint, they're going to be a 1-to-1, right? Because there's a tech sitting at the door or a nurse, somebody sitting at that door watching them. So please make sure you pick that. And then of course, after that, your orders are in place and you're going to work off the MAR and just kind of go through each one of them. Like I said, not going to spend a whole lot of time. I'm saying we're hitting this one out of the park about 90% of the time. So everything is fine. Times look like they match. Everything looks pretty good. The biggest issue with our seclusion and restraints is your MHTs not documenting the red safety checks. So this red check mark up here is the one for the MHT flow sheet for seclusion and restraint. It is 50%. So please, please, please make sure if you put someone in seclusion and restraint, someone is sitting at that door, someone has a tablet, and they are documenting the red safety checks every 10 to 15 minutes on that patient while they are in seclusion and restraint. We have gotten finally the order of tablets. So we have 18 additional tablets just for the nursing department. So the excuse of, well, we only had one tablet or it was dead, there's no battery, we didn't have a tablet at all, does not work anymore because we have them. So please make sure that your tech has the tablet and they are sitting and doing these rounds. This is where we struggle the most. The nursing documentation looks amazing, but the MHTs are not doing this component. Or the nurse, again, whoever is sitting with the patient. Treatment plans, again, this goes into your MAR. If you go to the MAR and say you need to add a treatment plan for the seclusion or restraint, then you will hit edit, and eventually it'll ask you what the problem is. If you just type in seclusion or restraint, it'll automatically pop up for you. Hit OK, and your plan is there. If you get this far, wonderful. If you go further and you want to hit those interventions, add goals and interventions, you're going to want to pick one for nursing and one short-term goal, one from nursing, and one from the MD. So usually it's patient is going to verbalize feelings of, what led to self-harm or what led to harming others. And then your usual doctor and nurse goal is going to be, we're going to medicate them and probably talk to them afterwards, say what happened. Those are two interventions that are there. Those are ones I usually pick. You can see here, provider will initiate and adjust medications, and the RN is going to offer PRN meds. That's it. We need one from nursing, one from the doctor. Therapist will go in and add the rest of theirs the next day or later. Again, if you get this far, wonderful. If you just put in the top part and you say, I don't know what to put in for an intervention, again, that's okay. I'm looking at them and those I can fix because they're not time stamped. This just sums all of that up. Again, the biggest thing is your MHT restraint has to be done every 10 to 15 minutes. It says 10 minutes. It should be done every 10 to 15 minutes while that patient is in seclusion. Please make sure that you're reminding your tech that they're doing these. 1 hour face-to-face, usually not a problem. We know we have to call the doctor 1 hour after at the 1 hour mark, call them after we do the face-to-face. Again, document that time and what the plan is, documenting medications, of course, updating treatment plan. Pain management. So this, if you were here last year, you know how annoying this was. Every time you gave a pain med, you had to call a supervisor. Luckily, we don't do that anymore. And we got the policy changed to every 2 hours. We must be reassessed within 2 hours. I know the MARs are still kind of messy. We have new phlebotomists here. They're working really hard to help clear out some of those red items on our MARs so that you can start to really use the system properly and you can see the document response purple to remind you as a visual cue. But in the meantime, if you give someone pain medication, within 2 hours, you should be going back in there and hitting doc response. Pick if it was effective, not effective, and make sure you pick a number. Is it 1, 0? And then hit save. If it, and that's it. This is still, I would say we're at 80% probably, maybe 60%. But please make sure you're documenting the response within 2 hours. If you forget to do it within 2 hours before you leave your shift, go in there, doc response. It will allow you to change the time and you can backdate your time to within the 2 hours and then hit save. The other thing with the pain, please make sure you're paying attention to which pain medicine you're giving for what pain level. For example, ibuprofen 400 for pain level of 1 to 4, but then the nurses will put on there, it was a pain level of 7 headache. Well, that medication wasn't ordered for that 7. It was ordered for a 4. So now you've given medication outside of what it was ordered for, which is a med error. So please make sure you're paying attention to that. If the patient doesn't have an order for 7, then you're going to have to call a provider and get them an order for 7. We try to catch those when the doctors only put half of the order in. We try to catch them. If you notice that, hey, they have an order from 1 to 4, what do I do if it's a 5? You can write that order in there from the provider. But please making sure that they match. We do see a lot where it only goes up to 7, but they had a 10. So you're administering medicine outside of the range. So please make sure you're paying attention and documenting response, because there's no way for us to catch all of this. What will happen is a surveyor will come on day shift. They'll go up to the nurse on any cottage. They'll say, did you give out any pain meds? Or is anybody on any pain meds? And that's how they will identify which chart to look at. And we're just going to go back day by day by day and kind of hope that everybody documented their responses appropriately. Fall prevention plan. You do this as part of your intake assessment. There is a Edmondson fall assessment built in. Of course, if a patient scores higher than 90, then they should be placed on a fall risk. And then we start a treatment plan for risk for falls. If a patient has a fall during the time that they are here, during your shift, please make sure that you are documenting it in your nursing note. So again, if did the patient have a fall during the shift, you hit yes, a whole nother little section will pop up. You fill all that information in, and now you've documented that fall. And then of course you do your incident report. If you have already done your note for the day and your patient falls towards the end of your shift, you can go back into your note and hit update and then do the fall note, or you can type in the table of contents fall note and it'll come up by itself. But please make sure you're documenting the falls on the patient. Falls policy, we do not do red socks. We had red socks for a little while. We've taken them all off the cottages, so we don't do that. If a patient is a fall risk, they have yellow socks, a yellow armband, yellow, their banner says they're a fall risk, and then of course we do the falls treatment plan. That's it. No red. If anybody asks, there's just yellow. Initial treatment plan, crisis care plan, not going to spend time on this because those are done as part of your standard admitting orders, and you guys do those 99 out of 99 times, so no big deal. Towards the last little pieces we're going to go over is our medication rooms. At this moment, we only have one nurse in intake. She's only here during day shift 3 days a week, which means we may start seeing more home meds come to our units. If a home medication comes to the unit, please make sure that you are logging it appropriately and bagging and tagging it and either sending it to pharmacy if it's narcotics or putting it in a secured bag and in this cabinets on your med room. I put this in here because we haven't had to do this in a couple months because we had nurses in intake. But please make sure that you are doing the home medication form, listing all the meds that they brought, doing that form in HCS, and then you can just print a copy of it, put it on the bag, and we're done. Now we have the meds inventoried. If there's narcotics, of course, those have to be counted by 2 nurses. We're trying not to get these to the med rooms. We've got a couple of different stops in place in access, but I did have some that went to the med room this weekend, and the nurse on E2 had to process them. So I wanted to make sure to include this for you guys because we haven't had to do it in a while. Glucometers. This is always a question when Joint Commission comes to the units. So please make sure that you know how to clean them and that you know what the vials should be labeled at. So we have dedicated glucometers for each unit, so we shouldn't be moving them around. We don't have any inside the emergency bags. They're all in the cottages, so we don't have to look for them. This sign will be up in the med rooms, hopefully by the end of this week. So remember, the strips are 4 months from the date that you open it, and you should be labeling the container. And then the test solutions are 3 months, and you should be labeling the vial, not the box, in case we get rid of the box, right? So 4 months for strips, 3 months for vials. This was asked to one of the nurses, how do you clean the glucometer? And the answer they gave them was with alcohol pads. That's the wrong answer. How do you clean it? With the sandy cloth. With the purple tops is how you clean it. Wet the whole thing, let it dry for about a minute, and then wipe it down again with a new one, and then we're done. So technically you have to wipe it twice. So you wipe it once to get the initial gunk off, I guess, and then you do it a second time, let it dry. I think it's a 2-minute dry time. There'll be directions in the med room as well on how to do this, but the answer is we use the sandy cloth, wipe it, and then let it air dry, and then it's clean. If it's to clean it. So do not say anything else but purple tops, which should be in your med room. Assignment sheets. Assignment sheets have to, per Joint Commission, have to be completed by the RN on duty, by the charge nurse or the RN. I know sometimes your MHT leads will do these. That's not okay. The assignment sheet needs to be done at the very beginning of the shift by the RN. You're responsible for who's going to be doing what and making sure everybody knows. Please get this done, I would say within the first 15 to 20 minutes of your shift starting. The finding that we got, the surveyor walked on the cottage and it was around 11 and it hadn't been done yet. The nurse said, oh, I was doing meds, we had a code, we had this, I was going to do it. And they didn't care. Because how did you know who was going to respond to the code? Because you never assigned it first thing that morning. So please make sure you do this as soon as you get to the unit, right? As you're wiping down those nurses' stations and getting ready to start, go ahead and knock this out. We will be walking around checking to make sure that it's done, and we want to make sure it's done early. Oxygen storage. Oxygen is flammable. It should be stored away from smoke. We do have carts and we have racks or boxes in all of either in the medication room or in your treatment room on your unit. So you want to make sure you know where it is in your specific area. And then as we have little tags that we put on there that tell you if they're full or empty. The racks also say full or empty. And so that's how we label it and know where there are. If Usually not a problem with the oxygen. We don't usually leave it unattended. The finding that we got was for E1 or E2. The oxygen was not easily retrievable. There was like 4 or 5 wheelchairs from the door, wheelchairs and then oxygen. And so that was the finding was you have oxygen stored, but you can't even access it because I got to jump over wheelchairs. So just making sure that you know where it is and that it is tagged, which we're checking all of them now, and they are, and then that you can access it. Again, not a big finding. Chat, I am doing some of these with you guys as I'm going through and auditing your charts and looking to see things that are missing. I'm sending you a chat through HCS. It's not punitive. It's so we can just have a dialogue as I'm finding things. So you'll see when you log into HCS, it'll go ding, and you'll see a little red bubbled on the right bottom right corner, and it'll just say that you have a message. It'll be me saying something like, hey, this patient was admitted and they scored a 22. They should have been severe high risk suicide. So that you start remembering those kind of things. It may have a question asking, why didn't we do a dietary consult because the patient's BMI was high, or don't forget to hit save on your initial assessment. So stuff like that I find as I'm going through the chart. Again, it's not punitive. It's really just to get you in the remind you more in real time of what I'm seeing in the chart based off your documentation. Now, 99% of the time you will go, it'll have a link to your patient. You can find what I'm talking about because I'll put intake assessment. And if you go look at it, you're gonna say, well, everything's fine. Yes, because I probably fixed it, or I edited the precautions, I updated the precautions, or I added the treatment plan. But it's again to get you to start making those connections. Other than that, I have nothing else. So do you have any questions? Okay, well then, thank you and have a happy new year.